I'll turn off my phone.
Well, in the
I don't need a
interest of
full
time,
hour.
let's get started.
You know,
Good afternoon, everyone. Welcome to Pediatric Grand Rounds. I'm Dr. Jay Shankar, Gayatri Jay Shankar. I'm one of the general pediatricians here. Most of you may be familiar with the process, but just for new people who may be here, let me reiterate that the first thing we need you to do, I feel like Vanna White or something, is to call into that number that's listed on the screen and put in your event ID. Now, medical students and residents, even if you don't need CME credit for it, this is how we keep track of the number of people who attend, so we do need you to do this also. If this is the first time that you're calling into that number, in the next week or so, you will get a text from CME asking you to identify yourself so that they can ensure proper credit. The other thing that I do need to remind you is to make sure you fill your evaluations at the end of the session. Again, these are very, very vital to us for us to be able to continue the Grand Round series, so please take the time to do that at the end of the session. It is my great privilege and pleasure to introduce to you Dr. Marcela Popescu for her Pediatric Grand Rounds today. Dr. Popescu came to us here in ETSU in 2008, I believe. She initially did her medical training in Romania. She had actually done her medical schooling as well as a complete residency training before she came back here and did her residency training in University of Chicago at Illinois, following which she got her hematology oncology fellowship at University of Wisconsin in Madison. She stayed on there for a year, was involved with several grants and projects there, and since 2008 has been here with us as a very valued member of our ETSU faculty, as well as with the St. Jude's affiliate clinic that we have serving our hematology oncology patients in the area. Dr. Popescu has been very productive with numerous presentations, articles, posters at various sessions, and has actually done a Grand Rounds for us a couple of years ago on this. And so in fact, this is an update on what's ongoing at the St. Jude's Clinic, and a very, very important piece for all of us who are involved in the clinical care of these patients. So I'm very excited to listen to her updates on the improving time to antibiotics in febrile neutropenic patients that's coming out of our St. Jude's Clinic. Dr. Popescu.
Thank you for having me. I think it's fair to say this is a project that might have started in pediatric oncology and St. Jude's Clinic, but is definitely a group effort that involves our university and our children's hospital. I had the good fortune to join this pediatrics department at a time that the children's hospital just opened. I actually came to Johnson City 3 months before the grand opening of Niswonger Children, so I joined at the right time in a brand new facility with an amazing group of people. You've heard educational sessions and lectures on fever neutropenia. You also heard about our quality improvement project a bit over 2 years ago. This is mostly an update of, how did we start, what did we achieve, and where do we go from here? But it's definitely a joint effort, that, as you can see at the bottom of that slide. I have nothing to disclose. I wish I had. The objectives for today will briefly review the febrile neutropenia. If you look at the ABP certifying exam content outline, you'll see that neutropenia, the definition of it, the initial management of the patients that become febrile, the signs and symptoms of septic shock do have quite a bit of weight. So I think hearing once more about this medical emergency and the management of it is in everybody's interest. We will underline and look a bit at the data out there that it's new, that shows that timely antibiotic administration is vital for these patients. Very briefly, will review some of the quality improvement methodologies so you can easier understand our thought process and how our project was started and then continued. And then we will go over the data of our FNN project. So in pediatric oncology, we define the fever as a single temperature that reaches 101 Fahrenheit or a persistent temp above 100.4. And that's what we tell our parents and families. The neutropenia is defined of an ANC count, and you'll see ANC is calculated by WBC count times neutrophil percentage, and you always, if you have bands, you add them to the neutrophils. Is defined as a count below 500. This is really the definition of severe neutropenia that we use. Less than 500 cells or a falling number. If we know that the patient is likely to have a falling ANC in the next 48 hours to below 500, then if you're below 1,000, you're going to be managed the same, okay? Please keep in mind that our institution actually adds to the fever and neutropenia definitions the patients that are immunocompromised and have a central line, even if they're not neutropenic. So the suspected neutropenia patients will be managed initially the same. Children that are not oncology patients but do have chronic neutropenia diagnosis, even without central line, will be managed similarly as well. And then any sick patient, if the patient is an active chemotherapy patient that appears sick and is neutropenic even without the fever, please manage the patient as an FNN patient. The neutropenic fever, and I'm sure everybody that takes call on the second floor knows that, is really the most common cause of unplanned admission in our patient population. Every time we hospitalize these patients for fever, we will hold their myelosuppressive chemotherapy, and it makes sense that they will have impaired survival because of the chemotherapy adjustments being made. Having an infection and being hospitalized also does impact their quality of life, and it comes at a substantial cost. We also know that fever and possible or confirmed neutropenia is a medical emergency. It needs to be treated as such. These children can progress very fast, and we are unable to predict who will develop septic shock. Thus, the prompt antibiotic administration is imperative. Some of these children will have evidence of an infection, a bacterial infection. Depends on the data that you look at, 20% and up to a third of these patients will be bacteremic. The mortality in children is lower than in adults, but still we do lose some patients to fever and neutropenia. The majority of patients will be managed on the floor. And now we are hoping to avoid some of these hospitalizations because it became routine standard of care in patients that we predict there will be neutropenic secondary to chemotherapy administration for the next 5, 6, 7 days. We will choose to prophylact them with oral antibiotics at home. You'll see more and more children coming in with prophylactic antibiotics. It makes you wonder if our standardized approach to hospitalize all of these children is not a bit too much for the patients that will do well outpatient. Again, there's more and more data, and I was surprised at how many groups actually are looking at managing some of these patients that we think are low risk as outpatient, and it seems to be appropriate for some subgroups. It would be preferred for the children to be managed outpatient, maybe with an ER visit. It would decrease the risk of antibiotic resistance, prolonged costs, prolonged therapy, and nosocomial infections. But you also need to have the infrastructure that you need, and you need to have the families that are compliant and have the means to get that child to medical attention immediately if things worsen at home, which in our area really, and mostly because of geography, we went back and forth as a group. Can we go more towards sending these children to the emergency room and manage them as outpatient? And we cannot reach a consensus, but again, some of our families do live 2 hours away. We can identify some high-risk features in our pediatric hematology oncology population. The fluid malignancies patients are at the highest risk. To fight bacterial infections, we all need the same things. We need some defense mechanisms. We need barriers. We need mucosal and skin integrity. Chemotherapy disrupts that. The absence of foreign bodies. These children have central lines. We need to be able to mount a cellular response, to have innate immunity, polymorphonuclears. These children are neutropenic, so the signs and symptoms of infection will actually be subtle because they cannot mount that cellular response. You need to have adaptive immunity, B cells and T cells. The children with leukemia and lymphoma most of the time will be lymphopenic because of the type of chemotherapy that they receive with heavy-duty steroids. There's been much effort, and more so in the last 5 years, to identify the patients that are low risk and select them from the high-risk patients. There have been efforts to develop pediatric scores. Adult oncology has that tool now standardized, to develop pediatric scores that would predict the risk of bacteremia in these patients. It's extremely difficult to standardize decision rules in a patient population that is so heterogeneous and a clinical condition that has numerous variables like fever, neutropenia. So there are efforts out there, and I'm sure at some point we will all have a standardized approach, but we're not there yet. So why all this focus on QI projects and patient safety, and in our case, fever neutropenia management? First of all, it's a requirement for all of us, as you know. But joke aside, we do owe our patients to deliver the best care we can every day and in a safely manner. Recently, it's been shown that the time from arrival to delivery of that first dose of antibiotic in fever and suspected neutropenia patients is associated with outcome. Delays with adverse effects, and of course, meeting that time to antibiotics in a timely fashion with improved outcomes. I apologize for the quality of these slides. The scanner broke. This first study that you're looking at had a large number of admissions for FNN that they looked at. It came out of Texas, and they looked at few adverse events, and it was clear an association between that time to antibiotic and PICU transfer, need for fluid resuscitation, and mortality. Surprisingly, it was not associated at all with the length of stay. But there are other groups looking at the same impact on outcomes. Time to antibiotics is really used as a quality measure in almost every institution that has pediatric oncology these days. And it's been used to rank our institutions in the last 5 years by the US News and Reports. Using QI methodology, it's a tool that allows us to look at how we do things, identify the breaks, the failures, and fix the system. It provides you with the means to change for the better. So for all these reasons, our FNN project was started. Quickly, this is all news for most of you, and bear with me. The first thing when you start a QI project, you ask the question, what am I doing here? What is actually the goal? What am I trying to accomplish? Then you're looking at the hows. How am I going to accomplish that goal? And what can I do? What kind of changes can I implement? What kind of new things I can test to make sure that I achieve that goal and then maintain it? You all know the 4 stages of the PDSA cycle. You plan your change to test and implement. Then you do the change, you do the testing. Then you look at your data before and after that change was implemented and see what lessons you've learned. And then you plan your next change. That's what PDSA cycle is. This is a roadmap, if you want, of the quality improvement process. It starts with the aim. That needs to be a SMART aim. And you can use those initials. S means it needs to be specific. You need to clearly state what are you trying to achieve. M stands for measurable. How do I measure that improvement? A means it should be achievable. You should not plan to make a change that cannot be achieved by the team you just put together. It should be relevant to the institution that you work in. It should be FNN was a relevant goal, improving time to antibiotics for our Niswanger Children's Hospital and St. Jude's Clinic's priorities. And T, it should be time-bound. You should set the time frame. I would like to achieve this goal by that particular time. Once you define your aim, you identify a team. What are your key players? For example, in our case, the residents, the people taking care of the patients that come in with FNN, the nursing, inpatient and outpatient in both those settings. We don't involve the emergency room in our institution, but a lot of other institutions do. The pharmacy, because they will need to receive the order and deliver the antibiotics. The nursing leadership to oversight the process. Those are your team members, your key players. Then you look at your data. You map your current process, and you identify the breakdowns in that process, because where your failures are, that's where you're going to need to intervene in order to achieve the change and the improvement following. And your key drivers are really the what's. And once you try to fix, you implement the changes to fix your failures, you completed a PDSA cycle and you repeat the process. I hope you can follow that. So how did we start? We started by looking at the first 15 months after the opening of Niswanger Children's Hospital. And we retrospectively reviewed all the FNN admissions. And our selection criteria might not have been that inclusive. We only had 31 admissions. And we realized when we looked at the time to antibiotic that we are not doing too good. Our average time was 168 minutes, 168 minutes. Our median time was 2 hours and 31 minutes. And we learned by looking at the process where the delays occurred. Around the same time, we had few patients at affiliate clinic sites that we lost in induction for ALL to sepsis. So we were asked by the mothership in Memphis to look at our process and review the charts because they wanted to know how the sites work differently compared to St. Jude's Memphis and what can we do to improve the system for this to not happen again. So we used actually prospectively, the next cases that came in, reviewed those charts and turned that data in to Memphis to be part of the domestic affiliate project. At that time, we had these 6 sites. We were one of them. The Memphis, Tennessee, is the mothership. The other 6 were the older affiliates. We added Charlotte, North Carolina, and Tulsa, Oklahoma since then, in the last couple of years. And I realized you cannot really read this because it's too far. I'm only pointing at the time from arrival to antibiotic. And in green bar, you see that's the expected time. 60 minutes is standard of care. The red bar is the average for all 6 affiliates. And the blue is Johnson City. We did a bit better than 168 minutes because we knew this is coming. And this was prospective. So we cut down just by knowing that we will look at that data from 168 to 106 with some efforts placed in education, really. So the next step in this combined project was to develop an improvement plan for each of the affiliate sites. And we used the data that we learned from the retrospective review and then the next 10 cases that we analyzed. And we came up with a key drivers diagram, which is what we mentioned when we spoke about QI methodology. So this is our aim. It's clearly stated, and it has a time frame. And we want to reduce the mean time to antibiotic in 100% of the patients with fever and possible neutropenia to less than 60 minutes, as of right now, starting now. The key drivers that we identify, and I have to tell you that this is not complete. This underlines the most important key drivers, okay? I can't really fit everything on one slide. So we looked at our admission process, and we realized that we weren't set up to enter the patient in the system at the time of call and get that patient encounter number in the system before the patient's arrival, that our admitting office did not know that these are emergencies. We looked at trying to do things evenly. There were discrepancies between the staff in how we manage these patients even. So to have consistency, we developed at first on paper and then later electronic, as you very well know, a standardized provider order set that the resident will complete at the time of call before the patient's arrival. We use a time log as a reminder that you need to go back into that room and reassess the patient after antibiotic was given, for example. and to improve the documentation, because we realized from our retrospective review that we are missing data. We learned that the labs, the IV access, the antibiotic administration, and the labs were delayed because the patient came in without EMLA at the port site. We had patients that needed TPA because the line would not draw back, and we would wait for an hour for TPA to take effect, and no antibiotic would be given. So we had some intense sessions with inpatient, outpatient nursing and residents. And of course, families. We reminded them to put EMLA at the site at the time they leave the house, and if not, pain spray will be used. We improved communication when we realized the breakdowns in the communication. And we met periodically to analyze the failures. So you can do a root cause analysis to try to improve next time. And the patients that did not reach the target goal, we analyzed in that, and we reported it. Part of our improvement plan, we use this flow diagram to just underline, you see on the right side, the expected times. And I know you're all familiar, the residents are quite familiar with all this. It's mostly for the faculty that have never seen the improvement plan. You all know how our time log looks, and this is the revised one that just came out early this year. The written order, the on paper order set, was used as the backbone when we developed the EHR order set. And again, this is just another way to show the mapping of our process with the failures, parts, some of the failures, more important ones that were identified, and the interventions that were done prior to the patient's arrival, at the time of intake, and at the time of antibiotic administration. And we continue to collect and analyze the data. You need to make sure that you are actually, after you implement all these changes, you are showing improvement. Are things getting better? And if they're not better, or when they're not better, how far off are they? And what exactly caused that delay, that break in the system? So this data was again analyzed as part of the affiliate sites project. And again, there are many different time points that we looked at, but I want you to focus again at the time from arrival to antibiotic. The red bars are expected time, the 60 minutes. The blue one is where Johnson City started at 106 minutes, and this is the first interim analysis. And you can see we cut that time down to 57 minutes. So at the first analysis after the improvement plan implementation, we were already reaching the target goal. Now, we reached the target goal almost in the case of the inpatient admissions and initial management, and in part because the clinic was doing so well. I want you to understand, if you have the curiosity to look at how other institutions do manage fever neutropenia, you will see that clinic always does better than inpatient, and inpatient always does better than emergency room. It's pretty much around 30 minutes, 60 minutes, and 90 minutes for those three settings. And there are many different factors playing a role, and we can think of some of them easily without even having to analyze data. And some of it is patient flow. It's much faster through the clinic to do everything, including the intake. get to the antibiotic, get the patient monitored, and so on. The second interim analysis that looked at all the affiliates shows that all the affiliates at the first and second post implementation were below the 60 minutes target. Going further from this point on, that project was concluded, and St. Jude's only monitors their own data, and they looked at ours as part of the yearly audit. So we're kind of on our own, and the process should continue, and the monitoring should continue, and we should continue improving and patients' experiences and outcomes. So this is where we started at the 106. And this slide does not include the baseline retrospective data, which was 168 minutes. This was the first interim analysis when we hit the target, the second one when we did much better, and this is when we started being on our, just collecting data and analyzing it separately. And this is only our affiliate, of course, and our Niswonger Children's Hospital. But you can see that we are maintaining, and the last time we looked at the data with the help of Kami Kwang was it was March of this year. So this is really recent. And that's, of course, the expected time. This is average time, mean time. As you know, is not the best way to look at data because it doesn't tell you how far off the cases that are off are. So when you look at the median, and this asterisk really means I did not plot the median time for the retrospective data. When you look at the median, we're actually doing okay. This is when the common project stopped, and this is the next two analysis that we did. We are doing okay. A median time of 40 minutes is pretty good. So our initial intervention was education, education, education. At this time, we added the implementation that we implemented that improvement plan. And I think the biggest time players, the biggest players was the time log, the order sets being standardized, and again, being able to do something for that patient admission before the patient's arrival, especially for families that live an hour away. This point is when we actually decided to place in the automated medication cabinets in the Omnicells the interval doses of antibiotics. We always use cefepime, meropenem, or vanc added to cefepime or meropenem. Those are, for us, the first three-line antibiotics. When we placed those interval doses and you didn't have to do anything but really go, get the order, and go to the Omnicell, we saw a significant improvement. And I think that was the main player at that point in time. We standardized and used as a backbone the paper order set, and we developed the electronic order set, which I think is working well. But it's mostly you that, that does it. So I would value your input. And this is the last time we made a minor change when we revised the time log, which is the one that we currently use. So I don't look at this as worrisome. I think at this point, we should keep the same aim, and the aim is deliver antibiotic in less than 60 minutes to any of these patients. I don't think the goal should change to keep decreasing the median time. I think it's more important that we look at the failures, see how far off we are from the goal, and learn why, and fix it. I owe this to my coworkers in St. Jude because they are really doing a spectacular job. And they didn't have to, they didn't start, they started, actually the clinic started under 60 minutes to begin with. So there was not much room for improvement. They just need to maintain the good times. But I think the most significant part of this graph is where did the floor started? And think about all the turnover that the nursing staff went through. And this was a new facility. And the fact that for the last 3 time points we stayed below 60 minutes, I think is the biggest achievement. I know what caused this trend and the median time trend, and there were two cases that we analyzed. One was delay in accessing the port because of patient's behavior, and the second was wrong antibiotic delivered to the patient, was not administered. But those 2 cases changed everything. I can tell you that without those 2 cases, the floor looks quite great. So again, where do we go from here? It might sound boring, but we keep repeating the cycles. Because once you implement all the changes that you can think would make a positive impact, and once your process is that streamlined and working beautifully and consistently, you just need to look at the means for sustainability. You need to accomplish your goal consistently. And that's why we keep running the PDSA cycles. And as I already mentioned, I think the more important question to ask now is not just what our median times are, but are we staying below 60? And how many times, what percentage of the patients or what proportion of the patients we hit that target goal for? Again, this is the 2 cases that I mentioned. We need to do better. We need to do better. We need to stay as close to 100%. That would be the goal for the next cycle. So in conclusion, by looking retrospectively at our process, we learn where the delays happened, and we were able to identify the failures, the breakdowns. By developing that QI project, we were able to decrease the time to antibiotics from 168 minutes to 40 minutes. That's 75% improvement. And you cannot do that without using a multidisciplinary team approach. It is a team effort. Every single piece in the puzzle needs to do their part for this, for results to happen and outcomes to be good. The beauty of standardizing a care process by using QI methodology is that now, if you want to implement another change, if you want to use something new, a new test, you can do that and see right away if it works or it doesn't. You removed most of the noise. You made it really easy from this point on. And although I don't have the data to back up my last statement, I do believe that standardizing and having this process automating, it's gonna decrease the likelihood of errors. And knowing that we look at every single case individually. So repeating these cycles will allow us to maintain the good results and definitely keep our patients safe and improve their experience. And that is, again, the bottom line is we do this because we owe it to our patients. And we do need to do better and better and better on a daily basis. And I wish I had a photo with everybody that works hard to make things happen. This is just the St. Jude staff, but it's really the best team on earth. And they're the people that I spend more time with than with anybody else on earth. It's a good thing. These are my references, and if you're not too confused, I can answer any questions. Thank you. Can you repeat that, Gayatri? I can't think of one negative. I think actually that we don't talk, much about cost when we run a QI project because it's not necessarily the focus. Patient safety is the focus. You want to streamline a process like the FNM from call to the time of antibiotic because of patient safety, to improve the patient's outcome. But by streamlining this process, you actually save costs. You save PICU admissions. The last 2 times that I looked at the data, so that covers a year and a half, we had no PICU transfers. We had no mortality. Then the future, definitely. And again, there's a lot of emphasis right now to look at outcome. Length of stay is probably at the top of the list for our institution. Positive cultures, the number of patients that are bacteremic. Again, I can tell just by going through the 5 years of data, PICU transfers are low, and fortunately, we had no deaths. Cost would be difficult to look at, but I have no doubt that is actually improving. I saw no negative, and part of it might have been because the administration was actually aware, involved, and oversighting the process from the beginning. They were truly involved from the beginning. When we first initiated the retrospective analysis, they already knew about what we're trying to accomplish, and they were nothing but supportive. This started really a year after the opening of the hospital. And Claire can speak for the support that we really got from the leadership.
Well, wonderful job. I mean, the benefits of the QI process and the team we can see just from your slides. So, thank you.
Thank you.